So I want to talk a little bit about our presenter today. Jessica Castillo completed her medical training at Johns Hopkins School of Medicine and her residency and ID fellowship at Vanderbilt University, where she was also the chief fellow. She was the medical director of the International Travel Clinic here at Vanderbilt, and she's now an assistant professor of medicine in the ID division. She also spent a lot of her time at the Vanderbilt Comprehensive Care Clinic in Nashville, where she precepts many students, and she also cares for HIV-positive patients. She's a member of the Aging and Infectious Diseases Work Group and has really made HIV and aging her main research topic of interest. So we're really excited to see what she has to tell us about this morning and to hear more about HIV and aging. So we're going to pass it off to you, Dr. Castillo. Thank you for being here.
Well, great. Thank you so much. Let me make sure that that's, oh, there we go. Thank you so much, Jen, and thank you all for tuning in early. And with that, let's jump in and talk about HIV and aging. So first, I have no conflicts of interest to disclose. However, I do have a disclaimer. In the HIV literature, an older adult is defined as someone over the age of 50. This is not my definition. This is what's used in the literature, so I don't mean any judgment when I refer to older adults as those folks over the age of 50. So first, an outline and a roadmap for where I hope to take you in the next 45 minutes or so. First, I'll try to take a 30,000-foot look at the epidemiology of HIV and aging, and then dive into some of the unique clinical challenges for caring for this population, including the geriatric syndromes of frailty, cognitive decline, and polypharmacy. Next, we'll review the combined effects of HIV and aging on the immune system as one component of the complex and multifactorial etiologies of these aging syndromes we see in our older HIV-infected adults. And finally, we'll try to wrap up on more of a positive note, and I'll finish with some insights introducing the concept of resilience and some of the psychological components that have been identified to be important in successful aging that we should consider as HIV providers for this population in particular. So first, let's jump in and give a little bit of background into the epidemiology, and then we'll spend most of our time discussing some of the clinical challenges and clinical syndromes in this population. So first, it's no secret that thanks to the success of antiretroviral therapy, HIV-infected adults are living longer and the number of people with HIV are increasing. These data are from the CDC, and we now project that the current estimate of the number of HIV-infected people in the U.S. is 1.2 million people. With people living longer with HIV, the proportion of those with the virus who are over the age of 50, and that's what's shown here, I can get my pointer to work, what's shown here in the yellow line, the proportion of individuals living with HIV in the U.S. who are over the age of 50 has been gradually increasing. And it's projected by the year 2017 that more than 50% of all HIV-infected adults in the U.S. will be over the age of 50. At our clinic at Vanderbilt, the Comprehensive Care Clinic, we have seen similar trends. These data are from all patients who had an HIV viral load obtained at the CCC from the years 2011 to 2014. Not only has the number of patients increased, but the proportion of those patients who are age 50 and greater, as shown in the yellow and the orange bars here, has increased from 30% in 2011 to now 37% in 2014. Additionally, if we look just at those patients who had an undetectable viral load during these years, the change in demographics is even more pronounced, with the median age increasing from 46 years in 2011 to nearly 48 years in 2014. We also know that when older adults are diagnosed with HIV, they often present with more advanced disease. Additionally, over time, the proportion of patients diagnosed with HIV are increasingly of older age. These data are from NA Accord, and while a little bit dated at this time, they noted that from 1997 to 2007, the proportion of patients presenting to care with a new HIV diagnosis who were over the age of 50 years increased from 17% to 27%. Additionally, as shown in this graph, during the same time period, at every time point, whether you're looking at the median cell count at diagnosis, which is shown in the bars, those adults who are over the age of 50 had lower CD4 counts at the time of HIV diagnosis compared to their younger counterparts. Additionally, those presenting with an AIDS-defining illness at the time of HIV diagnosis remained higher among older adults compared to those in the younger groups. Once in care, older adults with HIV continue to have worse HIV outcomes despite antiretroviral therapy. They have less CD4 count recovery with antiretroviral therapy, often despite having higher rates of viral suppression and higher rates of antiretroviral adherence. They also continue to have an increased risk of disease progression to AIDS and an increased risk of death. Interestingly, the current DHHS recommendation for ART initiation at all CD4 counts may be most important for older adults entering care. This was a study published by the SENESCENCE group that looked at 10-year mortality of patients entering care, all with a CD4 count over 500 between the years of 1998 and 2013. So everybody in this study at the time of entry into the study had a CD4 count over 500, and they looked at the effects of delaying ART initiation until until CD4 count had dropped to 500, 350, and 200, and stratified by age. And you see that for the older adults, those in the 45 to 65 group, the difference in mortality by CD4 at initiation and delaying ART initiation was greatest for the oldest group, with those with the lowest CD4 count at ART initiation with markedly higher 10-year mortality compared to those with higher CD4 count at ART initiation. The effect of that in the younger groups was much more diminished. While the higher risk for poor HIV outcomes among older adults is striking, in clinic we face the growing burden of multimorbidity in aging HIV-infected adults. Compared to their uninfected counterparts, HIV-infected adults experience higher rates of cardiovascular disease, cancers, metabolic disorders, osteoporosis, renal disease, and liver disease. And for some of these conditions, HIV-infected adults not only experience higher rates, but earlier onset of disease. Together, this means that our older HIV-infected patients have higher rates of multimorbidity. And this is shown in the study that's shown on the right side of the screen here. This study examined the number of comorbid conditions in HIV-positive and matched HIV-negative adults over the age of 45 years. So those in the white bars, the proportion of patients with no comorbid disease. The gray have one comorbid disease, darker gray have two comorbid disease, and the black groups have more than 3 comorbidities. And you see very quickly, even by the 50-year-old group, a shift in the pattern with a greater burden of multimorbidity in the HIV-infected adults compared to their uninfected peers. The burden of multimorbidity will only be compounded with the increasing proportion and increasing absolute number of older adults in care as predicted. This is a study from researchers in the Netherlands that was recently published in Lancet Infectious Diseases, and it's a statistical modeling study that aim to predict the changing demographics coupled with the burden of multimorbidity anticipated in the national Dutch HIV cohort. The study predicts that by the year 2030, in the Netherlands, the median age of HIV-infected adults will be nearly 57 years of age, and 73% of all HIV-infected adults in the Netherlands will be over the age of 50. And this shift in the age distribution is shown here on the left. On the right, they showed that the growing proportion and absolute number of older HIV-infected patients in care will also result in an increasing burden of multimorbidities in the patients in care by 2030. And while these studies and the ones here in the U.S. have focused on resource-rich settings, it's anticipated that with the growing availability of antiretroviral therapy around the globe, that we can expect these epidemiologic changes to also occur in resource-poor settings increasingly over time. But to take a step back and attempt to put together worse AIDS outcomes, worse immune recovery, more patients, more comorbid conditions, really, how can we begin to synthesize all of this into a comprehensive understanding of HIV and aging? Indeed, how do we see the forest? And this is the perspective where I think the field of HIV and aging is particularly helpful to provide. One model that has been proposed is that of Dr. Justice from the VAX cohort. And this is a model that tries to incorporate all of these complexities into an understanding of HIV and aging. Her model proposes that all adults, including those infected with HIV, begin the aging process with a set of presenting conditions. So these could include HIV or co-infections such as hepatitis, also environmental or behavioral exposures that we know can affect aging, such as alcohol use or tobacco use. These conditions affect an interacting pathophysiologic processes of aging, including immune dysfunction and senescence, microbial translocation, chronic inflammation, medication toxicities, oxidative stress, and multimorbidity. Cumulatively, these processes result in an incremental loss of organ system reserves, and this is really the hallmark of the definition of frailty. Once in this vulnerable state, one may progress to advanced clinical manifestations of aging, such as cognitive and functional decline, organ system failure, or a loss in independence and function, resulting in hospitalization or nursing home placement. And eventually, the aging process results in death. Let's now dive a little bit more deeply into some of the specific geriatric syndromes pertinent to aging HIV-infected adults. And for the purposes of time, I'm going to focus on frailty, cognitive impairment, and polypharmacy. So first, frailty. Well, what is frailty? Frailty is a state that we often know it when we see it, but may not have thought as much about what it really means. So for example, I think we could easily identify the gentleman on the left as being frail, and the gentleman on the right as being not frail. Frailty, as defined in the literature and in geriatrics, though, is a state of increased vulnerability to poor resolution of homeostasis after a stressor event. And this nice review in The Lancet describes it further. This means that following a minor illness, such as a urinary tract infection, one's functional status is compromised, perhaps to the state of dependency, and does not return to the pre-stressor event of functioning. So thus, here in the green line would be a non-frail individual who experiences a urinary tract infection, loses some of their function, but then is able to return back to their baseline following the minor illness. In comparison, a frail individual who may be still independent at the time of their event suffers a much greater hit to their functional abilities, takes longer to recover, and may not make it all the way back to their baseline functional abilities following the same insult. Thus, frailty is a state of increased vulnerability, and it increases the risk of adverse outcomes such as falls, delirium, or disability following a relatively minor illness. This process over time can lead to a global loss of function, independence, and even has been associated with increased risk of mortality. Biologically, frailty is a multi-system state that first begins with one's genetic factors coupled with our environmental exposures during our lifetime. These combine to lead to a cumulative molecular and cellular damage, ultimately resulting in reduced physiological reserve of multiple organ systems, including the brain, endocrine system, immunologic system, skeletal muscle, cardiovascular, respiratory, and renal functions. The loss of organ system can be mediated through such activities such as nutrition or physical activity, but ultimately reduction in the physiologic reserve places one in the frail state, such that if one experiences a stressor event while in the frail state, it can result in disability, falls, or increased care needs, ultimately feedbacking to further reduce the physiologic reserve and create a cycle of gradually worsened function and loss of independence. Well, frailty is not a new concept in HIV, and in the pre-ART era, HIV-infected adults were noted to have an increased rate of meeting frailty criteria. However, even since the introduction of ART, HIV-infected adults continue to have higher rates of frailty compared to their matched peers. This is a recent study from the MAX cohort, which is looking at HIV-infected and HIV-at-risk men, and they used one type of measure for frailty that is called the Fried frailty phenotype in the literature. Their study found that by the age of 50, the HIV-positive men, those with the black diamonds, had a higher proportion of study visits meeting frailty criteria compared to the HIV-uninfected men. And this higher proportion or greater likelihood of demonstrating the frailty phenotype persisted through the ages, so losing some statistical significance with smallest numbers in the oldest population. This pattern of higher rates of frailty has been reported not only among men, but also HIV-infected women in the WISE cohort and also in international cohorts. And importantly, frailty continues to be an important predictor of mortality in HIV-infected adults, even with antiretroviral therapy. This was a study from the ALIVE cohort, so this is looking at injection drug users from 2005 to 2008, and comparing those who are HIV negative and not frail in the blue line, those who are HIV negative but frail in the red line, HIV positive and not frail in the green line, and the HIV positive with frailty in the yellow line. You see that those HIV positive adults who also express the frail phenotype have the worst survival of the group, and this is compared to both the HIV positives who are not frail or the HIV uninfected with or without frailty. Thus, frailty in the setting of HIV continues to be an important marker of risk of mortality. Moving from frailty into cognitive disorders, let's now discuss cognitive decline in the setting of HIV and aging. And first, a review of HIV-associated neurocognitive disorder, a common neurologic syndrome in HIV-infected adults. Importantly, the rate of HIV-associated neurocognitive disorder, or HAND, has not changed from the pre to post-HART era, and it's estimated that 50% of all HIV-infected adults in care may carry an underlying neurocognitive disorder diagnosis. However, since the introduction of antiretroviral therapy, there's been a reduction in HIV-associated dementia, which now constitutes only a minority of HAND cases, and an increase in mild neurocognitive disorder, which is MND, estimated to be present in approximately 17% of HIV-infected adults, and asymptomatic neurocognitive impairment present in perhaps 28% of HIV-infected adults. The main difference between MND and ANI is whether or not these cognitive impairments that can be detected on neuropsychological testing result in symptomatic or functional impairment. So asymptomatic neurocognitive impairment means that someone has neurocognitive impairment on testing but doesn't express or isn't aware of any functional impairment symptomatically in their day-to-day life. Whereas mild neurocognitive disorder is diagnosed as having mild to moderate impairment in at least two cognitive domains with resulting mild to moderate functional impairment. HAND is important because it doesn't just include deficits in memory, but it also includes deficits in concentration, attention, working memory, comprehension, and even motor effects. Importantly, if someone with HIV is diagnosed with the asymptomatic neurocognitive impairment, approximately 40% will go on to develop symptomatic neurocognitive disease in the future. We also know that HAND is most strongly predicted by the HIV biomarkers of CD4 count and viral load. With this background of high rates of neurocognitive disease in HIV-infected adults, a research group in San Diego asked the question of whether the presence of HAND increases the risk of aging-related cognitive decline or dementia. In this study, they examined the outcome of mild cognitive impairment, defined as a translational state between typical cognitive aging and dementia, defined for HIV, which is present in HIV uninfected populations at 5 to 20%. They examined HIV infected and HIV uninfected adults and excluded the HIV positives with a symptomatic neurocognitive disease. They found that HIV-infected adults, compared to their matched HIV uninfected controls, had a 7-fold increased odds of meeting criteria on neuropsychological testing for mild cognitive impairment. Additionally, this effect seemed to be greatest among the oldest HIV-positive adults. However, among the HIV-positive adults, mild cognitive impairment was not associated or correlated strongly with underlying asymptomatic neurocognitive disease. So just looking at the HIV-positive group and whether or not they had mild cognitive impairment present or absent, the group looked at which of those individuals had asymptomatic neurocognitive impairments based on the criteria used for HAND. And of the 12 individuals that had mild cognitive impairment in HIV, only 5 also met criteria for ANI. Thus, aging-related cognitive decline appears to be a separate syndrome from HAND and remains still more prevalent in the HIV positives compared to their uninfected peers. This group also asked a slightly different question. Does older age increase the risk of HAND, both symptomatic and asymptomatic syndromes, in HIV-infected adults? They examined older and younger HIV-infected and uninfected adults in San Diego over the course of the year. They found that HIV seropositivity was associated with a 5-fold increased risk of incident HIV-associated neurocognitive disease. However, there was no statistical modification by age, meaning that the prevalence or the incidence of HAND in the younger HIV-infected and the older HIV-infected groups was similar across the year and was not statistically higher, at least in this small study, among the older groups compared to the younger group. So again, this seems to highlight that HAND is a separate syndrome affecting HIV-infected adults that is separate from aging-related cognitive decline. Another concept in geriatrics that is particularly relevant to cognition is that of polypharmacy. Polypharmacy is defined in the literature as a daily use of 5 or more medications. Almost by definition, many of our HIV-infected adults in care on antiretroviral therapy meet criteria for polypharmacy. This graph shows unpublished data from our patients at Vanderbilt by age and the number of medications listed as daily use, and this excludes their antiretroviral therapy. And what we see is with increasing age, a greater medication burden, such that approximately 80% of adults over the age of 60 are on more than 5 medications in addition to their antiretroviral therapy. In older adults, polypharmacy has been associated with a number of poor health outcomes. It's associated with medication complications, importantly, adverse drug reactions, drug-drug interactions, or drug non-adherence. Polypharmacy can also result in cognitive decline, falls, frailty, and loss of function, and has been associated with higher risk of mortality. Additionally, many risk factors for these poor outcomes associated with polypharmacy are highly prevalent in our HIV-infected adults in care. Among all aging adults, an accumulation of comorbid conditions associated with aging increases the risk for polypharmacy complications. And we know that our HIV-infected adults have even higher rates of these diseases, including cognitive decline and renal and hepatic disease, which could affect drug clearance. HIV-infected adults also have higher rates of changes in body mass composition and loss of lean muscle mass, which can affect drug distributions in the body. And unfortunately, HIV infects often have more psychological and social risk factors that could further increase their risk for polypharmacy complications. In summary of this section, we know that there is an increasing number and an increasing proportion of older HIV-infected adults in care. And we know that these individuals often carry a very high burden of comorbid conditions, even higher than those in their uninfected peers. Additionally, and taken more globally, they have higher rates and higher risks of geriatric syndromes, including frailty and cognitive decline, and a holistic perspective in the approach to the care of the HIV-infected adult is needed and needs to incorporate some of these geriatric syndromes. So moving on now, we'll dabble and just wade a little bit into the waters of HIV aging and immunology. There's no doubt that studying aging syndromes in HIV-infected adults is complex and interrelated. Not only are HIV measures, such as history of AIDS or CD4 count nadir, but also comorbid conditions such as depression, decreased cognition, diabetes, and social factors, all important and interrelated to lead to geriatric syndromes and outcomes such as frailty in HIV-infected adults. But to narrow our focus, the immunologic measures, including aspects of immune deficiency and immune activation, have been a particular research interest and have been shown to be important in the pathophysiology of aging outcomes in HIV-infected adults. Well, and why might this be the case? There are a number of features in the immune system that occur with aging that are mirrored in the setting of HIV. And for our HIV-infected older adults, many of these effects appear to be synergistic and even further increased. So first, in both aging and HIV infection, we see a shift from naive to memory T cells. Aging and HIV infection alike both result in a loss of thymus volume and function. Aging and HIV infection alike both result in increased measures of T cell activation. And these markers of T cell activation have been linked to a higher risk of some of the comorbid diseases we spoke about earlier. T cells also have a loss of co-stimulatory molecule expression and increased markers of terminal differentiation and clonal expansion. And in both aging and HIV infection, there are increased measures of systemic inflammation, such as serum levels of TNF-alpha and IL-6. And again, in older HIV-infected adults, the results of aging and HIV appear to be synergistic and further increase these markers. These immunologic changes have also been shown to correlate with measures of not only comorbid diseases, but also function and geriatric syndromes in HIV-infected adults. So this was a nice study that was done by the group in Colorado that looked at some of these immunologic biomarkers and functional status in HIV-infected adults aged 45 to 65 with an undetectable viral load. And they looked here at functional testing as assessed by frailty, a short physical performance battery, and also gait speed. And what they found is whether you're looking at the proportion of CD4 cells percentage, CD4-CD8 ratio, markers of CD8 cell activation, those groups with the higher functioning group had higher CD4 cell percentage, had higher CD4-CD8 ratio, had lower markers of CD8 T cell activation. And in looking at some of the markers of inflammation, those with higher functioning had lower soluble CD14 measurements, lower IL-6 measurements, lower TNF-alpha measurements, and statistically, interestingly, no difference in the low and the high functioning group looking at CRP levels by function. So again, these measures of immune function appear to correlate with measures of geriatric syndromes and function in older HIV-infected adults. Understanding the immunologic processes that are driving some of these aging outcomes in HIV infection is an area of ongoing research as we look for ways that we can modify and improve aging outcomes in HIV-infected adults. So finally, I want to wrap up on a very different note and introduce the concept of resilience and to delve a little bit into what can we do as providers to improve some of the health outcomes in our aging HIV-infected adults. So the concept of resilience generally involves two components. First, one has to have an exposure to a significant adversity, and then in the face of that adversity, develop a positive adaptation despite that. And in my mind, I think of this as basically the inverse of frailty, the ability to face something bad and bounce back, maybe even stronger. In HIV, we could apply the concept of resiliency to a number of domains. We could think about in terms of physical resilience, such as cognition or multimorbidity or function. We could think about resilience in HIV in immunologic terms, such as CD4 count recovery following ART initiation. From a population or epidemiologic standpoint, we could apply the concept of resilience to understand things like cohort effects, survival bias, and disparities. But where most of the research has been done is in the realm of psychology and resilience, and how resilience is important for one's ability to overcome things like stigma, poverty, isolation, and depression. Studies of older HIV-positive adults have shown that psychological resilience, and particularly the components of coping, self-efficacy, hope and optimism, and social support, has benefits beyond just mental health. HIV-infected adults with higher measures based on psychological testing for these components of resilience also report higher levels of health-related quality of life measures, including physical well-being, function and global well-being, and emotional well-being in the face of higher rates of life stressors, both general, such as financial, or HIV-related, such as stigma. And this combines to result in a higher or better sense of successful aging in this population. This is a cross-sectional study also performed by the group in San Diego that looked at HIV-positive and negative adults ranging in age from 48 years to 84 years. And they examined the components of self-reported successful aging by some of these predictors. Of note, they found that HIV-infected adults reported lower physical and mental health components, happiness and resilience, as well as higher perceived stress and more negative life effects. However, the HIV-positive sample also had a slightly lower median score in the successful aging scale that they used, with a median of 7 versus a slightly higher median of 8 in the HIV-negative controls. However, for both the HIV-positive and negative adults, a higher self-reported successful aging score correlated with improved physical and mental functioning, lower depression scores, increased happiness, increased resilience, optimism, personal mastery, and lower perceived stress. And while some of these are difficult for us to affect, many of these we can help address and promote through the services and relationships we build in our clinics. So in conclusion, I hope that we've discussed in the last 40 minutes or so and made clear that older HIV-positive adults are a growing and complex patient population in our clinics. And we really need a holistic approach and awareness of some of these geriatric syndromes when we approach their medical care. The causes of their health conditions are complex, including some immunologic changes that appear to mimic and amplify those of natural aging. However, while this seems like a daunting challenge for us clinically, we also know that building resilience through therapeutic relationships and promoting things such as optimism and hope in this population is one way to promote successful aging. I'd like to acknowledge and thank my many mentors at Vanderbilt, both in the ID division and also the geriatrics division. I'd also like to thank providers and leaders of the Vanderbilt Comprehensive Care Clinic, my funding sources, and most importantly, I'd like to thank my patients who continue to teach me weekly about important things like resilience. And with that, we can turn to questions.
All right, thank you, Dr. Castillo. We really appreciate your presentation this morning. We know you have another meeting that you need to get to, but we do have a couple of questions.
Sure.
Just a reminder to everyone, you can type your questions in the Q&A box, so click on Q&A at the top of your screen. You can type your question there, hit enter, and we'll see it. And then anyone who has a microphone attached to their computer or is using a telephone to view us, you can raise your hand and we can unmute your mic and you can ask a question that way. I would like to know a little bit about if there's been any studies based on the effects of HIV and aging if you were infected at, say, 25 compared to if you were infected at 40. You know, how does that change the process?
I think that's a really good point, and I think that really speaks to there's really two different things that we're talking about with HIV and aging, and they do appear to be different. So there's the issue of what happens when you're diagnosed with HIV at older age. And those, I think, goes back to some of the earlier slides where folks who are diagnosed later in life tend to present with more advanced HIV disease. But really in looking at aging with HIV and the folks who are diagnosed at a younger age and then have developed decades of exposure to the virus really are two different populations. And there have been studies looking at those two groups. And many of the issues surrounding multimorbidity and comorbid disease is really speaking to those folks who are aging with HIV and the cumulative effects of that, compared to those who are diagnosed later in life and may have the worst HIV outcomes or HIV markers at diagnosis. So it really is two different concepts. Thank you for helping to clarify that.
Thank you. We have a couple questions that have come in here. So one person wants to know a little more about the San Diego study, and they're wondering if any of the information was stratified by CD4 count or the length of HIV infection. Were the cohorts broken down in any way?
Unfortunately, many of these studies were pretty small. I'm not sure if they're speaking to the successful aging. There's a couple of San Diego studies. That group seems to be very interested in all of this. I don't recall in any of those San Diego studies that they were able to really control or stratify by CD4 count in some of those HIV biomarkers that you would think would certainly be important, and that may have been due to the small numbers in their studies.
Okay. And we have another person that asked if you know what percentage of new HIV infections occur among people that are 50 and older.
Yeah.
I don't know offhand.
So the data from the NA Accord study, which cites data up until 2007, so a little bit dated at this point. So in 2007, 27% of adults in the U.S. were over the age of 50 at the time of HIV diagnosis. And I'd expect that number has increased since that time.
Okay. Let's see, we have another question coming in. Someone asked, what are some of the factors or suggestions for improving resilience? Do you have any examples of any conversations you've had with patients or anything that's worked for you?
You know, I think it's all anecdotal at this point, and like I said, I find the concept of resilience really compelling and something, again, almost you know it when you see it based on patients that we meet in clinic and who've been able to overcome so much in their lives. But I think trying to really grow and foster and reinforce things like hope and optimism, trying to recognize and identify self-efficacy and help our patients see that in themselves and in their stories. You know, I think it's all anecdotal. I don't think we have a randomized controlled trial in terms of how do we build resilience. But I think looking for it and helping our patients recognize that in themselves, something that I know, you know, it was a big reason that drew me to HIV and why I love my clinic, is something we can try to reinforce and help our patients feel proud of and foster when we're talking to them in clinic. But I don't think there's a great study. I don't have a great study to point to in terms of randomizing folks to resilience versus not.
Right. No, I think that was good info. Dr. Castillo, I think it's a great place for us to stop this morning. Thank you so much for doing this. And
my pleasure.
Our next webcast Wednesday, you'll be receiving more information later today. And thank you, everyone, for tuning in.